Hello, everybody. Thank you for joining us today for the second webinar in our peer-to-peer webinar series this fall, which is brought to you by the National Collaborating Center for Methods and Tools. My name is Claire Howard, and I'm a research coordinator at the National Collaborating Center for Methods and Tools, and I will be moderating today's webinar. So we're just going to go over a few housekeeping items to start. Please use the chat box to send your questions. Make sure to send your questions to all participants and not just privately to host. There will be several question and answer opportunities throughout the webinar today, but please send your questions in the chat box at any point during the presentations, and we will make sure that they get answered during those question and answer periods. If you can't see the chat box, it should be in the panel on your right-hand side of your screen. If you can't see it, just hover over the slides or anywhere on the screen, and you should be able to see a little blue button that has a speech bubble in it at the bottom of the screen, and if you click on that, the chat box will open up. We also recommend using a wired internet connection today. If you do encounter any technical issues, the phone number for the WebEx 24/7 helpline is on the slide. And under panelists, you will also see Kate Turner, who will be helping to support our webinar today. So if you have any technical issues, please feel free to contact Kate, and she can help you troubleshoot those issues. So after today's webinar, the slides will be available online in both English and French, and they will be approximately 2 weeks after today's webinar. And a recording of today's webinar in English only will also be posted online as well. You should be able to see the links in the chat section, and you can also always check our previous webinars page for the recordings and slides for any of our previous webinars. We will also be posting links to the slides and recordings on our social media accounts, which are Twitter, LinkedIn, and Facebook. So we're just going to get started today with a quick poll question to get a sense of how many people are joining us today. So how many people are watching today's session with you? Just me, 1 to 3 people, 4 to 5 people, 6 to 10, or more than 10 people? So it looks like most people are just watching it by themselves, and then we do have a group of people also joining us. So welcome everybody again to our webinar today. We're happy to have you joining us. So thank you again for joining us for our peer-to-peer series. This webinar series is designed to share success stories of evidence use or building capacity for evidence in public health practice in the real world. And this will help demonstrate that evidence-informed decision-making, or EIDM, is achievable for anyone working in public health. So just a little bit of background about the National Collaborating Centers and the National Collaborating Center for Methods and Tools. The NCCMT is one of 6 national collaborating centers across Canada, and together the 6 NCCs are the National Collaborating Centers for Public Health. Each National Collaborating Center focuses on a different public health priority topic area. The NCCMT is located in Hamilton, Ontario at McMaster University, and our mission is to enhance public health practice and policy in Canada by providing leadership and expertise in evidence-informed decision-making to Canadian public health organizations. So to support our mission, the NCCMT offers many products and services through our website to help build capacity and apply evidence-informed decision-making. So we have the Registry of Methods and Tools, which is a collection of over 270 methods and tools for knowledge translation and public health. Our online learning opportunities, which include our 13 online learning modules that help build skills for EIDM, and include topics such as searching for literature, conducting critical appraisals, and implementing and evaluating knowledge translation strategies. We have many more online learning opportunities, so I highly suggest that you check out our website for those opportunities. We also offer workshops. We have Public Health Plus, which is a repository of high-quality pre-appraised studies and reviews relevant to public health. We also have several video series available through our YouTube accounts and on our website, including the popular Understanding Research Evidence series, which goes through concepts important to evidence-informed decision-making. And we also have a number of networking and outreach opportunities. So you may see us at a conference, and if you do, please come and say hi to us. So today's webinar will feature stories from the second issue of the Evidence-Informed Decision-Making Casebook. Issue 2 was launched at the beginning of October, and a link to the casebook is posted in the chat. And if you've not already done so, I highly encourage you to go look through the casebook and read the author's stories. So our first presentation today comes from Dr. Hergy and Cassandra Ogani at Niagara Region Public Health and Emergency Services. So I will pass it over to them to begin the presentation.
Okay, thank you so much for the introduction, and thank you to the National Collaborating Center for Methods and Tools for inviting us to share this work with you. This is some work that we think is having some early signs of success, and we're very pleased that we can share some of what we've accomplished so far with you. I'm obviously Mustafa Hirji, and Cassie Gurney is with me as well, and she'll be presenting the second half of this presentation. Sorry, just trying to advance the slide here. A quick, we already had the quick introduction to both of ourselves, so I'm not going to mention anything further on that. The outline of our presentation is thus. We're going to first talk quickly about the motivation of why we actually went about this and the objectives for the study that we developed. We'll then talk about the two phases of the study that we've completed so far, and with each phase we'll go into the methods and particularly the results, because I think that's what will be of most interest to people. We'll then touch on an impact assessment element, which is we're undertaking right now to validate some of the findings that we learned, and then we'll quickly summarize the lessons learned at the end of the presentation. Quick disclaimer, this was a locally driven collaborative project which was funded by Public Health Ontario, and we are very pleased that they were willing to support us financially to accomplish this study. The views that we expressed here, though, are only of us and the project team and don't represent those of Public Health Ontario. I mentioned it was a locally driven collaborative project, and the collaborative part of it is that the way these projects work is a group of local public health agencies get together to solve an issue of common concern. And so you can see here that there were 6 of us, local public health agencies, who got together to work on this project. And looking to our broader project team, these are all the different individuals who are involved. I want to also highlight the McMaster Health Forum was also involved in this project, and there was a great help, as well as the Middlesex London Health Unit has a hub librarian that supports multiple local public health agencies in Ontario, including ours at Niagara Region Public Health, and they were a big help. Finally, I just want to call out Allison Branston and Nicole Andruskevich, who are 2 part-time employees we were able to employ to do the bulk of the work, and they did a stellar job, and I think they should really receive a lot of the acknowledgement for the success of this project so far. So the origin of this project was really a couple years. We were thinking about health equity, and of course, we all know health equity is so critical to driving the health outcomes that people experience. But of course, health equity isn't really owned by anybody. Many different players have some role in this. So we in public health have some role. There's lots of advocacy groups and non-government organizations who are involved and have some impact on health equity. The social services sector, of course, has a huge impact on health equity. If you look at community health centers, they actually have in their mandate to address the social determinants of health. And this is just a few of them. There's many, many others. And so there's this whole constellation of organizations that are in some way are impacting health equity, but we're not actually really all coordinated. And so what we wanted to do is really try and put some thought into scoping out what does everybody do, And what is the role that makes sense for us in public health to be playing so that we as a big whole are actually being more deliberate and hopefully accomplishing more? And so that was really the origin of the project. And what we did at the time was we actually went out and we interviewed many of the agencies amongst many other initiatives. And what we discovered is that there was a few things that they thought that we could play. And a big theme coming out of that is that they felt that public health had a lot of data that could help inform the work that they do. Inform the work in terms of helping them orient and plan their programs, help them in terms of giving them evidence with which they could advocate and receive funding, even data with they could understand the problems that they're trying to address in the community better. And so that really led to this locally driven collaborative project to try and really see how can we actually take that data that our partners think is interesting and mobilizing in such a way that it's useful for them and actually impacts health equity. And so this led to our objective statement here, which is to identify the best practices to select, analyze key behavioral and health outcome data, and how to then distribute that data to our local community partners to enable them to advance health equity for the populations that we all serve. The short-term goals that we had for this was really just the mechanics of what data do we share, how do we share it, with whom should we be sharing it. So we want to understand what are community partners' preferences for which data and what methods it should be distributed. What are the current barriers that they experience when they do have data, and how can we try and solve them to make this data sharing exercise as useful as possible? And what are the ways that they might use this data so we can identify which data is most useful for them to be shared with? Those are, of course, very process outcomes. Our longer-term outcomes are, of course, these, and really the first one here is the most important, is that we really wanted to enable community partners to be able to reduce health inequities in the populations that they impact. Looking a bit broader than that, we were also hoping that we could maybe set up some stronger relationships, and that could be realized in terms of data sharing initiatives between us and local public health agencies, as well as our community partners. We are looking to maybe have a better understanding of community partners, understanding what our role is in public health and our data, as well as us understanding what their needs are, and particularly their needs in terms of data. So we had two phases of the project, and I'm going to talk about the first phase before I hand off to Cassie. So the first phase of our project was really to answer some of those short-term questions in a more concrete way. And we really had three parts to this. So the first part is we wanted to actually go out and actually survey our community partners to understand what do they use data for currently, what are the ways they would like to be using data, what would help them be able to use data effectively. The second part we did is we went to look at the literature, the published literature as well as the gray literature, to see what else has actually been done on this problem, what do we already know, and what are some of the lessons that we can be applying. And then the last part of this phase was what's called a deliberative dialogue, which is a mechanism whereby you take evidence, you bring the stakeholders who are supposed to use the evidence, and you have them grapple with that evidence to try and synthesize it and bring it to a high-level understanding. Of course, whenever something is published or there's data or evidence out there, it only tells part of the story, and the people who actually are on the front lines using it have more of a story, and they can provide context, and they can provide other tacit knowledge that may not be in those published studies or in those tables and graphs of data. And that's what the deliberative dialogue is really about, taking that evidence and really applying that lens so we can come up with something more useful. So in terms of our methods, to talk quickly about the survey, we identified 401 community partners that the 6 local public health agencies involved in this project already have existing relationships, and we sent that survey out to them. We had about 99 respondents respond, so that was about a 25% response rate, which we thought was quite good. In terms of the literature search, I mentioned we had a librarian helping us with that. And so the search constructs we were looking at were health equity, public health, knowledge translation and exchange, data, and community partners. We looked at Medline, Embase, and CINAHL as our databases, and we found 2,229 citations. Of those, we ended up doing a full text review on 17 articles and included 12 of them for the actual study. 9 of them were gray literature sources, 3 of them were published systematic reviews. With all of these articles, we critically appraise them using a mixed methods critical appraisal tool developed by McMaster University. And we had 2 staff independently review each article and then come to agreement on inclusion as well as on the strength of the evidence using the critical appraisal tool. Finally, in terms of the deliberative dialogue, what we did is we took the results from that survey, the results from the literature review we did, and synthesized it into an evidence brief. And that evidence brief had 3 parts. It discussed, 3 problems that are barriers to data sharing and use, 3 options that could be used to solve that problem, and then 3 considerations to keep in mind if we were to implement any of those solutions. And that provided a structured way for the dialogue to actually occur. We had what's called a merit review of the evidence brief, whereby the evidence brief was shared with other people who have some familiarity with this topic area, so they could review it and make sure that it does cover all of the key information. There aren't any major studies or any big gaps of data that we had missed and hadn't presented there. It's not a full scholarly review, but it gives you some elements of that. The participants of our deliberative dialogue were really selected from the survey response, and one of our questions was asking them if they would be interested, and we had about over 50 people who were interested in potentially participating. We tried to balance out our inclusion so that we had participants across all 6 local public health agencies and across the many different sectors and many different types of community agencies there are. And then we had a total of 16 community partners selected, and we then had 3 representatives of public health from our project team part of that as well. The McMaster Health Forum facilitated and ran the day where we had the deliberative dialogue, and that's a methodology that they're very familiar with and do all the time. And finally, at the end of the dialogue, we compiled a summary of and synthesized what was discussed there and shared it back with partners who had participated so that they would have the information to use going forward and that they could provide any additional feedback if there's anything we missed, which we found we hadn't when we prepared that summary. So very quickly, the results that we found from the survey, the evidence brief, and the dialogue here is that there's a few barriers that were identified. So the first one is a capacity limitation across organizations. For us in public health, we of course have limited capacity with our epidemiologists, and so there was a limitation for us to be doing this data preparation for our partners. But partners also were not that familiar with using data much of the time, and so the difficulty of analyzing, interpreting, finding out how to use that data was a limitation for them. It's identified that there's currently no universal data sharing strategy. By that we mean that every community partner, as well as us in public health, are really operating independently and not really taking account what are the needs of everybody else. And an element of that is that, of course, community partners are often applying for funding, and so while they are partners with each other, they are in some sense also competing with each other for funding, and that was a little bit of a barrier to them being more coordinated together. We identified there's a lack of support structure for data sharing work. That includes just having common elements by which we collect data so we can actually link different data sets by different groups and compare what we have, but also having sets of methods and best practices of how with different populations you go about collecting data. And then our partners expressed that because they aren't people who work with data and do research, they weren't familiar with the ethical processes to share data, but they thought it was very important that they take into account those ethical processes. And we're very happy to see that they were so conscientious about that. A few of the solutions that we identified through that process is that if community partners received interpreted data, so the analysis and interpretation had been done by us in public health, they thought that that would be much more helpful to them. They thought that if we had some enhanced data sharing networks, it might be a more regular way for us to share data amongst each other and take off some of that hesitation maybe some of them have towards doing that, knowing that the privacy and ethics have been looked after. As well, we could then start to standardize maybe some of the demographic elements we collect, so there's some alignment in how we're collecting data. The partner agencies we talked to felt that there could be some role for us in public health where we do have a lot of skills to maybe do some capacity building with them and build their skills as well. And then lastly, going back to that idea of hopefully having some data that we can link with each other and really making sure that if we're going to a certain population, we are consistent in the way we collect data from them, that we could define some universal methods that we could all share. So that's the knowledge that we came out of after phase 1 of the study, and I'll turn it over to Cassie now, who will discuss phase 2 of the study.
Thank you, Dr. Hergy. So all of that evidence that we gathered was then used to develop a process for sharing data with local community partners. And this is what we called phase 2. So in phase 2, there was, again, 3 different steps. The first one was conducting a pilot of the process for sharing data with local community partners. Secondly, was to gather feedback from the partners on the process and on the data that was shared. And the final step was to develop a guide to support other LPHAs sharing data with their local community organizations. So this is the process that we identified. Identify partners, conduct a consultation, provide data, and then finish with evaluation and collaboration. So I'll go into details about each of those steps. The first step, identifying partners. Findings from the literature and the dialogue for this project indicate the importance of trust between the LPHA and community partners for data sharing to be successful. LPHAs can recruit community partners with whom to collaborate based on common areas of focus. For example, if there's new data that's coming out on the health of school-aged children, you can reach out to community partners that work with that demographic, and they'd be more likely to use the data. Community partners may also self-identify by requesting data from LPHAs, or you may already have current ongoing relationships and you can utilize those. Secondly, conducting the consultation. Communication between the community partner and the LPHA is very important so that the data that is provided is considered relevant and in a format that community organizations can easily use. This requires meeting with the organizations to gain an understanding of their data needs and goals. The consultation should start by establishing common understandings about what data is, what data can be provided, what types of data the community organization would like to receive, and in what format. The survey showed that all the organizations collected at least some level of client demographic data. For instance, age was collected by 92% of survey participants, while health outcome data was collected less often. For instance, self-reported physical and mental health was collected the most, but still only by 63% of the respondents. The survey participants, however, indicated interest in receiving both demographic and health outcome data at the population level. During this step, the capacity of the LPHA also needs to be considered before committing to sharing data. The length of time needed to analyze, interpret, and provide data to partners depends on various factors, including if the data is easily accessible, if aggregation by socio-demographic variables is possible, particularly for smaller populations, if data needs to be cleaned, if different cycles of data, for instance months or years, need to be merged, or if data interpretations and recommendations for the community organizations are included. Step 3 is actually providing the data. The research is clear, as Dr. Hergy said, that even when community partners collect data, they lack the capacity to analyze and interpret it. This reduces their ability to use the data to inform program planning or evaluation and address issues of inequity. Thus, organizations would prefer to receive data that is already analyzed. Providing comparisons between local and regional or provincial data is also useful. This step includes providing the data packages as determined in the consultation to community partners in the agreed-upon format. For instance, a data report sent to the community partner electronically. Dialogue participants voiced concerns about data ethics, ownership, and privacy. Once it was explained to them about aggregated data, some of their concerns were alleviated. These concerns should be discussed during the consultation with the potential need for creating data sharing agreements or other ethics-related documents, depending on the sources and the level of analysis required. In order to ensure that the process of data sharing met the needs of the community partner, it is recommended to conduct multiple evaluations over time. For instance, at 6 months and 1 year after the data is provided. This will assist with determining if medium and long-term goals of the data sharing process are met. Additionally, sharing the data should not be the end of the road. In order to truly address health inequities, LPHAs need to collaborate with the local partners to address the social determinants of health. use the data for program planning, advocate for healthy public policy, and raise awareness of current inequities in ways that those inequities can be addressed. This step can also include the creation of more interactive data sharing platforms, networks for sharing data between multiple organizations, as well as open data sources. An important consideration in all of these possibilities is to make sure that the data provided is relevant to the data users and is in a format that they can easily use. If needed, specific training on the platform can be provided. So once we had that process in place, we piloted it with 3 local community organizations in Niagara, and they were chosen from the list of organizations that indicated their interest for future involvement in the online survey. And the 3 that we chose were based on the request for early childhood development data. An initial consultation took place between the organization and an epidemiologist and research assistant from Niagara Region. The consultation reviewed what data was available, what data the organization desired, and in what format. The epidemiologist collected, cleaned, analyzed, and prepared a briefing document specifically for each of the 3 organizations based on the consultation that includes summarized, aggregated data with basic interpretations. The data was then sent electronically to the organizations, and a follow-up meeting for the initial evaluation was organized. At the first meeting, the data provided was reviewed to ensure it was all understood. The evaluation included questions about the satisfaction with the data, its perceived usefulness, and the capacity of the organization to use the data. Similar questions were asked 6 months after sending the data, and next year in February, a final evaluation will occur to find out how the data was used in the longer term. Some initial evaluations of the pilot found it was well received by all 3 community partners. They considered the data to be comprehensive, they appreciated the comparisons between local and regional or provincial data, and all partners indicated interest in future data sharing initiatives. The partners agreed that the data was useful for identifying clients they might not currently be reaching, evaluating their services to determine why these audiences are not being reached or how they can do so better, and demonstrating a need for additional funding or services to address these service gaps. Once we had done the pilot, then we created a guide for data sharing. So based on the results from phases 1 and 2, we created the guide which aimed to outline the processes of engaging in data sharing with community partners to improve health equity at the local level. The guide was developed to assist local public health agency staff to share data with their local community partners. So after the 1-year project that we had to work on this LDCP, we're now, as Dr. Hergy said, in the middle of a 1-year-long impact assessment. The main objectives of the impact assessment include evaluating how data provided to community partners in the pilot may affect their work on health equity-related issues. Measurements will include how frequently the data have been used for organizational processes, such as funding proposals and reorientation of existing programs, and how the data has informed decision-making. Secondly, to evaluate how the guide can assist LPHAs with sharing data with their local community partners. This will include surveying the guide end users and using web-based metrics to determine the number of times the guide is accessed online. These objectives will help determine if the project goals were achieved. So a couple more specifics about the methods that were used and continue to being used. First of all, we conducted an evaluation interviews with the pilot organizations at 6 and 12 months post-pilot to assess their use of the data. Secondly, we sent the guide to several listservs of LPHA staff, including the Social Determinants of Health, Public Health Nurses Community of Practice, and the Association of Public Health Epidemiologists of Ontario. And so 2 weeks after we sent them the guide, we then sent them a survey to the same listservs. And this is to assess the guide's content and usability. And then finally, in the new year, we are planning to conduct in-person and over-the-phone interviews with LPHA staff on their use of the guidebook approximately 6 months after the survey with those who indicated interest on the survey. And finally for today, we're going to look at the lessons learned. So first of all, what we thought worked well was consulting with community partners. We considered this important to build trust and gain an understanding of their data needs. Secondly, hosting the deliberative dialogue with community partners helped to gain an understanding of the barriers and facilitators they face relating to data sharing. And finally, having a diverse LDCP team from across Ontario contributed to planning the project, developing evaluation tools, and connecting with a range of community partners. What we would do differently if we had the chance, we would consult with other LPHAs outside of the project team to ensure the guide meets their needs and to encourage high uptake of the guide. We would increase the 1-year time frame, which limited the time available for team members to review and contribute to project materials. And thirdly, engaging in the longer pilot with more community partners across the province would help us to see how data sharing relationships develop over time and in different contexts. Thank you very much. And I believe now is time for questions, so I'm just going to pass the control back over to the host.
Great, thank you. So we do have some time for questions. If anybody has some questions, please send them to all participants in the chat box, and we'd be happy to answer them. Just to get started, I was hoping that, Cassie, you could expand a little bit on the timeline for phase 2. So how long did doing that second phase actually take?
Now I'm trying to remember. I think we split it about evenly.
Yeah, I think it had about a 1 year of funding for this project. Now, we did do a little bit of work beforehand, so that helped, but I think we had around 6 months where we are engaging in phase 2. Only about 3 to 4 months of that was actually the pilot portion. So, you know, analyzing data, sharing it, letting organizations use it for a while, and then surveying them how it was used was really only probably around a 3-month gap. So there wasn't a lot of time there, which is why we really felt we needed to do this impact assessment phase so we could get a better sense over the longer term of how it was used.
Great, thank you. So I was just more wondering if other public health organizations were to use this process, how long could they expect it to take to do that consultation with community organizations and provide the data?
Yeah, so I think there'll be a few variables to that, particularly what data are they looking for? Is it data that's all in one database versus multiple databases? What is the depth and complexity of analysis being requested? What we found is that really 3 to 4 month period was enough to do the consultation, analyze the data, get it out to partners, and have them have some time to use it a little bit. So within, you know, a couple months to 3 months, I think you could reasonably do it depending on what the needs of the organization are and which data you're working with. It might expand beyond that, though, of course, if there's more complexity or some of those other factors I mentioned.
Great, thank you. So I'd just like to remind everybody again that we will have time at the end of the next presentation for questions for both presenters today. So if you do have any questions for Niagara region, please feel free to continue to send them in. And with that, we'll move on to our next presentation today, which comes from Dr. Stephen Bornstein, Pablo Navarro, and Rochelle Baker at the Newfoundland and Labrador Center for Applied Health Research. So I will just pass the ball over to them.
Okay, so this is Rochelle. Just to be clear, I advanced the slides by using the little bar on the far left-hand side of my screen?
Yes, that's correct.
Okay. Okay, I think we'll start now with Stephen Bornstein, who's going to introduce our program and our...
Hello, everybody. Thank you for this opportunity to present to you a program that we've developed here at the Newfoundland and Labrador Center for Applied Health Research, of which I'm the director. The program is called CHRSP, and we will explain in some detail what that stands for and what it involves. But let me start with a quick overview of what this presentation is going to be. Next slide. So I'm going to start with a few words about the center and about the problems that we face. I will then pass the mic over to Pablo Navarro, who will talk about the program called CHRSP and how it solves our problem. Then Rochelle Baker, who's our communications manager, will talk about feedback and uptake, and then I'll come back online to talk about the lessons that we think we have learned and what they might imply for everybody else. So, for starters, a few words about NLCAHR. This is an organization that started in 1999 that has 6 or 7 employees, depending on when you look, that has an annual, relatively small annual budget of about $500,000 a year, which is funded partly by the Provincial Department of Health and Community Services, otherwise known as the Department of Health, and whose mandate includes building research capacity in the area of applied health issues, addressing priority health needs in the province, and above all, encouraging and supporting the use of research evidence in health decision-making in the province. Like a lot of other centers of this sort, we face a complicated challenge of getting evidence into practice, evidence into action. And you can look at this from 2 perspectives. The perspective of the researchers, that is us, whose challenge is how can we get them to listen to us? And the challenge of the research users, the decision makers, the clinicians, the policy makers, is how can we get them to talk to us? How can we get the best evidence from them? This is a challenge everywhere, but it is in particular a challenge in a place like Newfoundland and Labrador because of our unique socioeconomic demographic context. So let me tell you very quickly about what makes us so special. Our demographics are peculiar in that, one, a very high percentage of our population is rural, lives in small rural communities, isolated communities, small towns, and a significant portion of it is aging and aged. We have an intense series of population health challenges. You can see some of them there. When you look at the various tables that international and national agencies produce, like CHI on population health status, we're almost always near the bottom, unless they're upside down, in which case we're near the top. We have real problems of access to health care, largely because of the way the population is distributed across the province, a relatively small population in a very big set of spaces. We have other healthcare challenges as well, which involve health human resources and lack of same. And we have some decision-making challenges. That is, our decision-making bodies in the provincial government have thinned themselves out to the point where they really don't have much built-in analytic and policy-making capacity. But in particular, what we find is that all of the special features of this province incline our decision makers to look like the guy you see on the slide. That is, they don't want to listen to generic evidence done elsewhere because they say that won't work here. And for a long time, we didn't believe them and thought they weren't simply paying attention or didn't have the time or the energy. But we finally, about 10 or 12 years ago, came to the conclusion that they were right. and that we could fix this by developing a program that we call the Contextualized Health Research Synthesis Program, in which, as you will see, the crucial word is the C word, contextualized. I'm going to pass the mic over to Pablo Navarro now, who will give you some details about how this program works.
Hello, everyone. Let's talk a little bit about CHRSP. In a nutshell, CHRSP is really an integrated knowledge transfer initiative in the truest sense. It seeks to synthesize the available research-based evidence, largely from systematic reviews, and contextualize those findings so that they make sense to the decision makers that we're working with. And I'm going to take you through some of this. The original iteration of CHRSP was built around something called an evidence in context report, and this is the one that most fully attempts to capture both the synthesis and the contextualization of research-based evidence for our decision makers. Published to date, we have 19 EICs, which you can see on our website, and these tend to be in the neighborhood of about 50 pages or so, and we try to keep them no longer than that. Following some feedback from our decision makers, we realized that we also needed to provide something that wasn't quite as intensive, didn't provide as much contextualization, and could be turned around in a faster or more timely manner. And so we developed something called the Rapid Evidence Reports. And to date, we've published 10 of those. Now, moving on to still yet more feedback that we received just recently, we discovered that in some cases, decision makers aren't looking for an evidence synthesis as much as to understand what is happening in other jurisdictions, either within Canada or internationally. And so we developed something called a snapshot report. And these are, as indicated, jurisdictional scans of the potential policies and practices and interventions in areas where they're interested. And so far, we've published 4 of those. So the CHRSP 7-step method, which is really the foundation for our program, applies most directly to the evidence in context, the most exhaustive and the most thorough of our reports. I'm just going to take you through these quickly. The first step is really crucial, and that is to ask the health system. When I said that this was an integrated KT initiative, I meant it most wholeheartedly. From the very beginning, we work with decision makers, and when I say decision makers, we mean senior decision makers in the departments of health and the other department that has a health mandate, as well as the 4 regional health authorities within the province. We work with them to identify issues that are coming up on which evidence-informed decision-making is something that they want to do, that they think that they can do, and that isn't due essentially tomorrow, that has enough time for us to do the work with them collaboratively. And part of that process also involves setting priorities, and I can't tell you how important this is. Because we have 6 different partners, we have to find something that is going to be of sufficient interest to all 6, at the same time balancing that with some partners' interests that might be quite unique. So once we've asked the health system and figured out what the most important issues are, we move on to the next step, which is step 3. We build a research team. We're generalists here by and large, and so what we do is we recruit subject matter experts from within Canada, ideally, occasionally from international places. And we bring them onto a research team that also includes a senior decision maker, one of our champions, or rather one of our partners, pardon me, some of the champions that we have for CHRSP, some frontline decision people, researchers who are local, and other potential stakeholders, including a new addition is to have advisors from our Patient Caregiver Advisory Council or Committee. To provide perspectives from patients and caregivers as well. And that becomes the research team. Our 4th step is to synthesize the evidence. Now, I won't go into can you close the door, Stephen? I won't go into too much detail here. All of our CHRSP descriptions are available at our website if you want to find out how we do it. There is an element of searching, critical appraisal, and synthesis. One thing just to mention that we have discovered as we were doing CHRSP is that we needed to have a more standardized synthesis process so that we could compare projects against each other and the decision makers could have a sense of what a strong body of evidence was compared to a weak body of evidence. And towards this end, we developed a rating system, which again, you can find details on our website. The fifth step is the one which is perhaps of greatest interest to our decision-maker partners, and that is to place that evidence into context. Various research that may have been carried out in especially larger urban centers that have, for instance, several teaching hospitals within one city, rural settings that are actually only 30 minutes away from those centers, can come up with results that are quite different than if that program or intervention were implemented here. And those are the kinds of things that the decision makers are really keen on learning about and finding out about, and it's what makes the research evidence, in fact, relevant. It attempts to answer whether or not something could, in fact, work here. And in the course of doing that, we've come up with a template of sorts of the different kinds of factors that are of greatest interest and greatest impact to the province, and you can see them there on the slide. In step 6, what we do is we identify the implications. Now, please take note this word was selected very deliberately as opposed to recommendations because it provides a lot greater leeway for the decision makers to use our reports without feeling that they're being held to a particular choice that they don't actually get to make that we've made just based on the evidence. So it's evidence-informed decision-making. It's not evidence-determined or based decision-making. And this approach has worked really quite well because they see that they're much more welcoming to our reports and they're much more welcoming to the nuance that comes with those reports. In step 7 of our 7-step method, we report the findings, and we do this in a variety of different kinds of formats so that they are the most accessible to our audience. That includes, for the EIC reports, a full-length report, which we try to keep at 50 pages at a maximum, a 4-page executive summary, which is what we truly hope everybody reads, and a 1-page briefing note, which is essentially a cheat sheet in case anybody gets asked a question. We also have online companion documents filled with all sorts of research details, essentially the appendices of any report for the sake of transparency and reproducibility. And all of these materials are reviewed by an external reviewer, something akin to peer review, but just less intensive. So that's the 7-step method for CHRSP. I'm going to pass the microphone over to Rochelle, who is going to tell us about how CHRSP has or hasn't informed decisions.
Okay, thank you, Pablo. So the question, has CHRSP supported evidence-informed healthcare decisions in Newfoundland and Labrador? Well, our partners tell us, yes, it has. The next slides will outline what we've heard from our partners about Uptake. But before I get into those specifics, I'll speak directly to the process we use to get feedback. First off, we have to be patient. Moving from evidence into policy can take considerable time, since the evidence we provide is just one factor among many that health system decision makers have to think about. We check in with our partners about a year after publication to find out how the work on a given policy issue is progressing. But we've discovered that it's generally best to wait 3 to 5 years to find out whether the health system has actually moved from evidence into policy. So, once sufficient time has elapsed, we go back to our partners and we solicit feedback. And sometimes we get unsolicited and very positive feedback, which is also always gratifying. So whom do we ask? We ask our CHRSP champions, our health system leaders, context advisors, consultants, project team, everyone we invited to our dissemination event for each study. This can be anywhere from 20 to 40 people, and we invite the recipients of our brief survey to pass the questions along to any relevant people in their own organizations. This helps when there have been changes in personnel, and it also broadens our outreach to the widest possible audience. And what do we ask them? Well, we used to ask them a lot of questions using a rather complicated feedback mechanism that involved a combination of paper surveys and online questionnaires. But as it turned out, decision makers are busy people. That method only yielded about 10 to 20% response rate. So we learned that we get more feedback if we make it easy for people to give feedback. The survey method that we use now involves direct emailing, 2 simple questions, and we get about a 50 to 75% response rate, which is really good for any survey. And here's what we ask. Was this report useful, relevant to your organization? If so, how? And we will outline some examples of how the report might have been used. And then the second question, if the report was not used, useful or relevant. Please tell us why not and how it might have been improved. And we ask them to outline briefly why the report wasn't used and tell us how it might be made better. We gather and record the emails we receive, and we maintain an uptake folder for each study. We report representative samples of stakeholder feedback online at the link provided here. Oops, I'm going backwards. Here we go. So far, we have received solicited feedback on 12 of our EIC studies published between 2008 and 2014. We've also received some unsolicited feedback on rapid evidence reports and some snapshot reports. Decision makers have told us that our CHRSP reports have been referred to by healthcare committees, by people serving on planning teams, and by decision makers at the executive level. Some reports with a clinical practice focus have been included in grand rounds. One report was used to help strike a new interprofessional health education committee. Others have been used by outside agencies such as law enforcement to inform new practices. The majority of the reports, 10 out of 12, directly informed the development of a new practice or a policy in the province. And I'd like to note here that the 2 studies that did not lead to a policy decision had findings that were too inconclusive to be the basis for a decision, such as the report on chronic disease management teams, where there just simply wasn't sufficient body of evidence, and an earlier study on childhood overweight and obesity, for which the language and approach around the issue was undergoing significant change at the time of publication. So we're now in the process of gathering feedback on our 2015 and 2016 studies, and what we've heard about our earlier reports has been so overwhelmingly positive, we're pretty optimistic that this trend will continue. So rather than go through all of the feedback we've received, because you can read it on our slides and on our website, I'll just read a couple of representative quotes. The Director of Mental Health and Addictions for the province wrote the following. The Memphis model for mental health crisis intervention was recommended to the All-Party Committee on Mental Health during its 2015 public consultations. When we looked into it, the CHRSP study on mobile mental health crisis intervention also supported its use. So in answer to your question about whether the report was useful, the answer is yes. CHRSP certainly supported us in being able to fund and support the implementation of the Memphis model in the province. Further to this issue, a CBC News report dated July 2018 stated the following. Using the Memphis model of mobile crisis intervention, 161 visits to homes were made in April 2018 compared to 84 visits in April 2017, a marked improvement in service delivery and support. And just as an aside, that's a team-based model in which law enforcement works with mental professional teams to de-escalate people in crisis with mental health conditions and to get them proper supports rather than putting them into the justice system. So, how do I get to my next one? Bear with me. Okay. And here's some more positive reviews. Of our report on age-friendly acute care, a senior government official wrote to us, this report is very helpful and examines the research within the Newfoundland and Labrador context, including the implications for decision makers in this province. This is a useful document as we consider outcomes for seniors in acute care and how we can improve them. It has been circulated to the regional consultants for acute care for their information and consideration when dealing with operational issues and in reviewing programs and services. As the result of this study, in 2017, Eastern Health in Newfoundland and Labrador piloted the province's first ever acute care of the elderly unit at St. Clair's Hospital in St. John's, a new intervention that was supported by the findings of our study. Again, these are representative examples, and there are more of them in the feedback outlined in our online report. So I'll pass the presentation back to Stephen, who's going to outline some final thoughts and lessons learned.
Thank you. I'm going to skip that slide and go right on to the lessons learned because there isn't a lot of time. First lesson is something that everybody knows, but we've actually demonstrated clearly, is that pull works much better than push. Studies that are proposed and prioritized by the decision makers themselves rather than being sold by us to them, get much better attention and uptake. So insofar as you can get your decision makers to demand that you do work for them, you're in business. In this context, relationships really matter. What we've succeeded in doing is building a 12-year-long partnership with the key leaders of our provincial health system. They look to us for answers. We do the best we can. This is probably easier in a small place like Newfoundland and Labrador, but I think is workable elsewhere. The third lesson is that context matters, and contextualizing both the questions that are asked and the results and the way we do the syntheses really improves the uptake. Reports that we produce no longer just sit on people's shelves. They actually read them, refer to them, debate them, and use them. The contextualization process that we have developed turns out to be quite complicated because it triangulates between institutional and organizational data on the one hand and people's informed opinions and experiences in interviews and focus groups on the other. But we have developed a template that helps us do that process in a careful and systematic and consistent way. In addition, in the next slide, what we've learned is that a small center in a small place can't have all the expertise it needs to do these kinds of complex, detailed studies. You need to combine local expertise and external, national or international expertise. In addition to that, an outside viewpoint is really helpful to make sure you know what you're talking about. Involving both researchers and the decision makers on each team, because as Pablo explained, each project team for the big reports has one of the 6 system leaders on it as a full member. Involving them on it really increases their integration into the process and their uptake of the results. Working quickly and communicating effectively is crucial. If you take 3 years to produce a report on a question that the system needs answers on urgently, it'll be too late. So we've managed to work within a 1-year framework, even for our long, full EICs. Furthermore, what we have started to learn is that while CHRSP was developed for Newfoundland and Labrador and for its particular circumstances, it can actually be adapted for use in other jurisdictions with similar patterns of characteristics and needs, and particularly for areas of the country or elsewhere that have large rural and small town populations. So in fact, we now have a proposal into CIHR for a big grant that will turn CHRSP from a 1-province program into a 3-province program in collaboration with Manitoba and Northern Ontario. So I think we're now open for questions. Thank you.
I take this and pass it, have it drag the ball.
Yes, thank you. So we do have time for questions now. Just a reminder again, please send questions to all participants in the chat box. Just to get started, I was hoping that you could expand a little bit on your building relationships point under your lessons learned. So do you have any tips or advice or suggestions that others could use to help build relationships like your team has been able to?
Well, one thing we did is to start with the top leaders. So our key partners are 2 deputy ministers with health mandates and the CEOs of the 4 regional health authorities. But we also discovered that one way to make that partnership work is to advise each of those 6 to delegate some helpers inside their organizations. We call them CHRSP champions. So each organization has both a leader on the CHRSP program and one, two, or sometimes three champions who do the hard slogging. So that helps. The other trick was to put the 2 deputy ministers on our board of governance for the center. So they, in fact, fund us, and I report to them. This has helped. Once they understand, once they figure out that they like what we're doing, this has really helped because we meet with them on a regular basis. Pablo?
I was just going to add that I think in terms of building trust, one of the things that's worked very well is that we periodically, and I mean quite often, go back to the decision makers, not too often, every few years or so, and we meet with them and sometimes some external experts to go over what we're doing and to find out what is and isn't working. So things like making sure that we're on their calendar for when they want to be asked questions or they want to find out about results, and how we're soliciting those topics from them. And in that process where they feel like they are being heard and the program is being adjusted to fit their needs better, then they develop a greater sense of trust that we will be responsive to them.
And what has happened is a kind of dual learning process. We've learned how to talk to them and to understand their needs and their time pressures and their budgeting processes, and they've learned to talk to us. They've learned how to ask questions that can actually be answered by research rather than just throwing things out and hoping we can answer them. So this is a process, it's sort of a feedback loop, and over the years we've changed the way we do things gradually to improve the techniques because we've invented this on our own basically from scratch.
And this is Rochelle. I just have one comment to make about relationship building from a communications perspective. We make sure that our communications with the health system partners we work with are centered around listening and are centered around hearing what they need and responding and being adaptive. I think our flexibility and our adaptiveness is really valued by them, and that's what they keep telling us, and that when we check in with them, we make sure that we're meeting those needs and that the relationship is really focused on them and not on us as the researcher. So that's just a touchy-feely answer to your question.
So the next question that's up here on the screen is, were there any reports that did not resonate as well with the decision makers, and what do we do about it? Yes, there were. In one example was a question that we were asked that the system immediately turned around and answered. So we were asked the question, does a province like Newfoundland and Labrador need a PET scanner? And as we were gearing up to put together the team to answer that, the Premier announced that they were buying one. So we were stuck with that decision. So what we had to do was retool the question so it wasn't whether the province should buy a PET scanner, but what did it need to know about a PET scanner when it decided to make the purchase? So we changed in mid-course, and they actually paid quite a bit of attention to that. Another report that didn't get much resonance was the one that was mentioned by Rochelle, where it turned out there wasn't a lot of evidence. That was the one on chronic care teams. A third one where there actually wasn't a lot of evidence actually turned out to be quite useful for them. So they asked us a question about dialysis, I think it was, where we discovered there wasn't a lot of useful evidence, but when their first reaction is, so what do we do? The answer was, you do whatever you're currently doing as long as it's not causing any harm, because the research literature is okay with what you're doing. So sometimes not finding any evidence actually makes the decision makers happy.
And in terms of the resonating of the reports, it's important to note that these reports are topics that are chosen by the health system. So there's a kind of built-in resonance for our health system with CHRSP. If it's a question that they've posed to us, it's something they're intrinsically interested in. It's an inherent part of the process. We're not, again, pushing the research at them. They're pulling it from us. They're telling us what they want to know.
Although we are occasionally tempted to give them a list of topics we think they should do, we resist that, don't do it, so that the topics are theirs. All we do is shape the issues that they propose so that they can be researched so that they're researchable. But it's always their topics, and it's their priority list. So they propose a long list. They then come up with a short list on which they agree, and they put them in a list of priority in terms of timing. So the resonance is built into the system.
Great, thank you for those answers. So I just have one more question for both groups. And I know, Dr. Bornstein, you just touched on this in your presentation as well. But how do you see your work translating across Canada? So maybe if we can start with you, Dr. Bornstein, and then we'll move to Cassie and Dr. Hergy.
Okay, what you discover when you talk to people doing similar work across the country is they actually do tend to contextualize their results, but often they don't do it in a very systematic way. So what we think is that evidence support teams across the country could borrow from us both the way we get the system to provide questions and then the way we shape the answers in a rigorous and methodical way to fit the needs and capacities of the system, so that what you will get on a given question, you could do a given question across the country and you get slightly different versions, province to province, or even region to region within a province. One of the things we hope to discover if CIHR gives us the money to do the 3-province rurally focused CHRSP program is the extent to which the answers are similar across 3 highly rural areas and the extent to which they're different, and the extent to which the questions that those health decision makers come up with in our 3 regions are similar or different, and the extent to which the priorities are similar, different, or can at least be harmonized. So ideally, anybody who thinks that, who has trouble getting their decision makers to listen to them might try to tell them that what they're going to give them is evidence about what will work for them rather than evidence about what in general works.
Great, thank you. And Cassie and Dr. Hergy, do you have any comments or thoughts about that question?
Yeah, so, I think there's an element of Dr. Borstein's presentation that's actually really relevant for us. And I think one element he's really highlighted is to listen to the, user and what do they need in trying to provide something to them. And so I think that's actually really relevant for us. The process we developed really started off with that consultation with the community partners of what their needs are. And I think that means that wherever you are in the country, whatever the context is, you're going to start off by setting up something that's going to be really useful to them. I think health equity, finding a way we can impact health equity, particularly getting all the different players who have some role and some impact on health equity, is a challenge that probably all of us across the country feel. And so we think this is, a first stab at something that could be helpful in mobilizing data to help solve that problem. And we hope that there'll probably be lots of innovations to that over time.
Great, thank you so much for that interesting question and answer period. So I'd just like to thank all of our presenters again for presenting today on their work. And I, again, strongly advise you to go look at our casebook and read their stories as well, as they have a lot of information in their stories as well. So if you are using EIDM in your practice, or you would like to support for EIDM, we urge you to contact us. Our email address is on the slide there, and it should also be in the chat box. And we usually respond quite quickly to your questions and comments. Your feedback is also very important to us, so we have a short survey today. The link to the survey is in the chat box, and the survey should also open when you close out of the webinar today. Our next webinar will be next week on December 6th, and it will feature a presentation from Region of Peel Public Health on their Knowledge Broker training program, as well as a presentation from Alberta Health Sciences on their Healthy Well Child Visit program as well. The registration link, again, should be in the chat box, and it's also on the slide. The NCCMT also offers several webinar streams in addition to this peer-to-peer webinar stream. So more information on these webinars can be found on our website, and the link is also in the chat box. So with that, I'd like to end our webinar today, unless there's any other comments from our presenters today.
None from New.
None from us. Just thank you very much for this opportunity.
Perfect. Thank you so much. And thank you to everyone who joined us today.